heard. Yeah, so he'll probably get here for the end of it, and that'll be okay. What's that?
It's just now.
Yeah, yeah.
As long as my frailty one.
It's gonna be what?
So this isn't going to be as long as my frailty one. If you were,
Everybody was feeling more frail by the time it.
no, we went too long.
Hello, hello, and welcome, every one of you. So glad to see you here. Thanks for coming. Now, can you all guess how much trouble I've had getting the names right this last month? EP. I just gone to calling them both EP. So I just this is well, they have one more week because it's the end of the year, and it's but they've been here 4 weeks. And even over lunch, I called Eric Ethan, or Ethan Eric. I can't remember that either. So glad you're here. So glad we're here. I might share with you. I use this little time that I've got, a few minutes before I introduce them, always to pass along things that are on my mind or might be going on, but also to share with you what we've done lately for the first time. So we've been out here 4 years, 4.5 actually, 4 years that we've had the resident physicians coming out here. It's been a great experience, I've got to tell you, I believe for them, for sure. Certainly has been for me, and I consider it a blessing to get to do this kind of teaching in this setting. And y'all have been so gracious. The people who live here have been so gracious with these guys, and you know how that goes because you've been through things like this in your own life. That kind of spirit communicates as encouragement, and that's what we all need: encouragement where we have confidence. And I see it blossoming in these guys. Well, last Saturday we graduated. What I think was that our 4th or 5th class. You should know, you were in it. 5th. It's our 5th graduating class of residents who've been through the 3 years of training. This is postgraduate after their MD or DO, 3 years. And now, as of last Saturday, he's a card-carrying internist. And that was a great experience. It was very, very low-key and small. But these 11 graduates and their families, and some of us faculty and other residents in the 2nd and 3rd year were there to congratulate him and to point out what they've accomplished. And it was really a high moment. It's, as you can imagine, it's a great thing. It's a milestone in their career for sure. And then Monday, for the first time since we've been coming out here in those 4 years or so, that we actually brought the brand new first year residents who are just arriving, just going through orientation. So they're the ones called interns historically. So they're first years. They came out, and this is the first year that we actually brought them out as part of their orientation to the whole program. We did tour them last year during orientation, but this year, I'll thank Quentin. He provided food through Bistro. That'll get them to come back. And we had a few hours of orientation here. They heard all about Butterfield, and then took a really nice tour. And so Jay presented, Jay Green, Beth Von Roble as chair of the Butterfield Healthcare Advisory Committee. She presented some things to them, including saying, "Here's what life is like, for us here at Butterfield, and then here are the kind of services that we need, related to healthcare, and she did a great job. And then your very own Jennifer Neal presented, and I had to hand them one of the calendars of events. I think that alone speaks for itself how much is going on here. And I told them what I'll tell you now. When I first arrived here, I thought, oh, that's great. We've got somebody doing programs and exercise and that kind of thing. So I just better get over there and talk to her and inform her and bring her up to date on the fact that Tai Chi, everybody ought to have access to Tai Chi, because they're, with the exception of aerobic exercise, there's more evidence, medical evidence in the medical literature of benefit for us as we get older from Tai Chi than there is anything else. Well, she already had 3 Tai Chi programs to go in, so there's not a lot you can tell Jennifer. She'll smile and humbly accept it, but she already knows. She is so good, and so she's easy to brag on what she does and the kind of programs she puts on here. And raise your hand if you've never been involved in any Jennifer Neal programs. Oh, you have too. When you raise your hand, you don't help me make my point. Okay, proves that we need a program on hearing, right? Oh, there you go. That's what I thought you were going to say. So anyway, we had kind of bookend events, the graduation, and then the visit to Butterfield by the first years, and for me that kind of summed it up. And I tell you, those people we gave diplomas to on Saturday, it seemed like they just arrived 3 months ago. And many of the ones that you know their faces because they've been out here, and just very, very proud of them, including this guy who is a member of that third year class, and so he's waiting to take off. We've kidded him about having a short-term attitude, but that's really not true. He's just as engaged as ever. But we're very proud of Eric Peeler, who is, well, I'll tell you, he's from Jonesboro, Arkansas. Grew up in Jonesboro, so he's an Arkie. Went to Tulane undergraduate. Went to UAMS for medical school. Came here for his internal medicine residency training of 3 years, and now has taken a job at Mayo Clinic. And he's one of 9 academic hospitalists hired this year by Mayo. They've got a lot. How many do they have total? Over 50. But they had spots for 9, and only 3 of them who were hired were from outside Mayo Clinic. So very proud that he was one of those, and that's going to be a good experience. Of course, we basically told him, we expect a little more from people from Arkansas, at least to know that the winters aren't bad here, but you're going to experience something different when you go to Rochester, right? Can anybody confirm that? Just okay. Tunnel? Oh, that's right. You can drive your car underneath those. I've heard of that. Well, it's going to be a great experience. And while I've still got the mic, and I've just seen 2 people come in from UAMS that I was hoping would make it. Dr. Dean Ezel is our new program director for the residency program. And straight here from Little Rock today, driving all the way up this morning and driving back this afternoon. I believe we've not met face to face, but I'm pretty sure this is Dr. Alice Alexander, who is Vice Chancellor. Thank you for coming. Vice Chair for Graduate Medical Education. I read that, in my defense, I read that off an email. Somebody else got it wrong too. So, okay. Welcome. So glad we're going to tour them around This is Dr. Alexander's first time here, and we're going to tour her around Butterfield Trail after this presentation. So, just introducing Eric Peeler, going to Mayo Clinic. He's going to make us proud of him. What I hope is he's a contact to get people in quicker. You know, once you get up there, they do a good job, but sometimes it's hard to. I'll go ahead. Are you going first? So, but even though Dr. Peeler's going first, I'll go ahead and introduce the other EP, Dr. Ethan Porter. Ethan grew up in Jeff City, correct? Went to my wife's alma mater, Westminster College, for undergrad, and went to A.T. Still College of Osteopathic Medicine in Missouri. We've had a couple of their graduates and who've done really well. So without further ado, I'll hand the presentation over to you guys and tell them everything they want to know about pneumonia.
All right, perfect. So we kind of do our rotating talks, and this was one that I don't know has been done before. If it has, it hasn't been. It's been a while. So we wanted to talk a little bit about pneumonia, what it really is, because I mean everyone's going to talk about it. Everyone who's had it or knows someone who's had it, or especially in the last couple of years, it's shown up in news and all sorts of iterations of things with the COVID pneumonia and all that stuff. And so we wanted to kind of bring it back to basics a little bit, make sure we're all talking about the right things, because as medical professionals, we have to be very precise in what we say, especially to one another. And so we wanted to start off a little bit with, some of our learning objectives and just kind of establishing a baseline before we go further on it. So our first one is really just to talk about what does pneumonia mean? What are we talking about when we say someone has a pneumonia, and kind of what are the different degrees of pneumonia? The next part is just talking about how we treat it, because you can approach it. Most people at severe ages or end of the ages have more severe disease, end up in the hospital, and so that management is very different than what we would do, for someone who's got it and is doing fine and can be treated on an outpatient basis. And so we'll go over a little bit of that, not too much in the weeds, but just so there's a difference. And then the last part of it is. Dr. Porter is going to talk about how we can protect ourselves against developing pneumonia or prevent it being severe. So just to start off with a definition of it, pneumonia itself it's an infection that causes inflammation in the air sacs of the lungs. Basically, you build up a lot of inflammation, and that causes destruction of cells, and you get purulent materials and things like that block up the airways, and then you aren't able to exchange oxygen as well as you would otherwise. And so that's what we're talking about. And you kind of at the base of it is we're talking about an inflammatory process that causes damage in the airways. And it can be from a bunch of different things. So, we usually talk about community-acquired pneumonia or ventilator-associated pneumonias. There have been a couple of different designations in the past, but they've all kind of rolled into these are the two most common. And then we've also got atypical pneumonias, which in the past you probably heard of walking pneumonia, and that's usually what that's referring to, is it's kind of a atypical presentation but still an infection that is pneumonia. A little bit here about some of the organisms. Mostly atypical pneumonias are going to be things that you can't grow very easily. And so, hence the atypical part of it was like we have to do further studies to know what it might be, or sometimes we just treat it and it gets better and then we say, oh, that's what it was. So here's a little bit of a breakdown of what we're talking about. And like I said, you get this infection from whatever the organism is. You develop a little bit of inflammation, as you can see, kind of the start of it in that second part, where you've got infiltration of the airways, and then you start to get inflammation, you start to get red blood cells coming into the area, and white blood cells and things like that to try to fight off the infection. And in the process, cells are dying and things like that, so you get all this debris that settles out, and usually some mucus and a few other different things, and they plug up the airways. And then there's inflammation in that fourth part where the cell walls or the lining of the alveoli start to thicken up, and it makes the oxygen transfer a lot more difficult. And so that's why people often are short of breath, need supplemental oxygen, or need to be on a ventilator. And then that last part of it is kind of the recovery part. So, you still have, and that's why you still have some lasting effects afterwards. You may still have a cough, you may still be short of breath. Even though the infection has kind of run its course, you still have to deal with the aftermath of it.
Yeah, and just a couple things to point out real quick. To just kind of orient you a little bit, the circles that you're seeing there on the bottom, those are representations of the alveoli. So that's the sac where the blood and the air is exchanging oxygen. And so as you see, as these pictures develop, it's getting just gunked up, clogged up. So you can't get that air through to absorb into the bloodstream, and that's really the big problem. And then he kind of hit on it a little bit, the resolution, if you look at the top, day 8 to week 4. So it can take a long time to see the full recovery, even at this, microscopic level. And a lot of times patients are just not very, don't have a lot of patience for that recovery sometimes. But you just have to remind them that it's going to take some time, and you'll get back to yourself. So.
And kind of carrying off of that, we wanted to talk just briefly about COVID. I mean, we could do an entire, series of talks about COVID and what we do or don't know and have and haven't learned and might learn and yada, yada, yada. So it would be, by definition, an atypical pneumonia, and that's typically what you see. Often people will talk about, single pneumonia, double pneumonia, those sorts of things. And I think we have some pictures a little bit later what that's talking about. But it's not so much the degree of pneumonia as it is the location. So you can have it in one little place, you can have it in one lung, or you can have it in both lungs. That's where the double pneumonia part comes in. So it doesn't necessarily mean you had multiple infections, it just means it was widespread on both sides. So COVID, in a general sense, and I put more up here if you want to read through it, and the slides will be available afterwards. But basically, our current understanding is the virus causes this huge inflammatory response throughout the body, mostly in the lungs because there's more of the ACE2 receptors there, and that's kind of what the virus uses to infect cells. And so you get this huge inflammatory response with a lot of damage in the alveolar spaces and things like that. And that's where we start to see the aftermath of it afterwards. He was talking about the prolonged recovery. We don't really fully know how much COVID or the SARS-CoV-2 virus affects different organs. So a lot of people have, fatigue is probably the most common thing I hear about. Shortness of breath, you get lung scarring from all the inflammation, kidney injuries, heart problems, things like that, because also tied to all of these things, it can cause additional blood clotting in places you wouldn't expect. So you can get pulmonary emboli. I've seen people who've had heart attacks because a blood clot formed in one of the vessels around their heart. Things that are weird, we just deal with it as best as we can. So, not to do any too much detail, but there is a little bit that COVID pneumonia is a type of atypical pneumonia. And this slide is here also a little bit for completeness sake. When we're seeing someone in the hospital and we're evaluating some things, we order a bunch of different tests. You've probably seen or heard of a lot of these or had them done yourself. Blood counts, signs of infection and severity of disease. Procalcitonin, some of these tests are up there for different reasons, and it's mostly for completeness sake, but a lot of it is like we use it to interpret how severe the disease is, how, over time we trend them to say, oh, this infection is getting worse, or it's actually getting better based on what we're doing. The one kind of more serious thing on there is the bronchoscopy with bronchoalveolar lavage. That's one of those things that the pulmonologist will do at the bedside, and you may have heard of it, where they put a camera in and they go look at the lungs and then they flush them out with some saline. The idea behind that is it's kind of that case where we don't really know what's going on, but it's really severe and it's getting worse quickly, or it's not getting better as quickly as we thought it was, and so maybe we're missing something. And so they'll go in, find the area where it's mostly infected, flush some saline in there and get samples from that, and they use that to culture. And so that's a very kind of obviously inpatient thing. You'd only do that for someone who is in the hospital, but that's kind of our last line of testing if everything else is not really helping us too much. So here's where we're looking at some of the x-rays And X-ray is one of those things that we use as a screening tool, but also as a progression tool. In most of these cases, we say the clinical, the imaging lags behind the clinical scenario. Oftentimes you can feel really crappy and your X-ray will look fine. And that's where the walking pneumonia comes in, as people will they'll feel kind of crappy, but they, not too much on there. And then you get a chest X-ray and holy crap, it's like totally different. And then, the recovery on the other side of it too can be the same, where you'll feel better, but then the imaging kind of lags behind and it still shows some inflammation. And so it's, don't get super panicky if it looks weird, and definitely ask for some help and guidance if you see, your chest X-ray in the hospital and the doctor can explain it a little bit better of what they think is going on at that point in time. So here we're looking at a lobar pneumonia, which is one of the categories of pneumonia. So you've got, here we're looking at it's probably right lower lobe. Yeah. Did they say middle? Okay. Yeah, so all of the lungs have multiple lobes, so the right one has 3, and the middle and the lower overlap each other, and so it's really kind of hard to tell which it is, but it's either lower middle lung or upper lower lung, if that makes sense. And so that's what we're talking about when we're saying it's a lobar pneumonia. It's just it's isolated to one lobe of the lung. Where here, this is what your atypical pattern looks like, where it's kind of all over, sort of diffusely inflamed. You couldn't point to one specific area that's involved more than the others. And that's, basically what COVID looks like on an X-ray if it's not too bad. So, we talked a little bit earlier about, the workup, the testing, the things you do, the types of pneumonia. And that's sort of all getting towards our decision-making process. If someone's coming into the hospital, or coming into the ER for shortness of breath or cough or fevers or things like that, and you get a chest X-ray and it looks like one of those, the first decision we have to decide is, does someone need to go in the hospital or not? Can we treat this as an outpatient, or are they going to need to be, potentially, put on oxygen or put on a ventilator, treated with IV antibiotics, that sort of thing. And there's a bunch of different calculators we use for that. There's one called the Pneumonia Severity Index, which I have on the next slide. And then after that, really the best steps are going to be supportive care. Fluids, drinking as much fluids as you can, staying hydrated. That's always the first thing that goes when you get sick. And then, supplemental oxygen if it's needed, even intubation and mechanical ventilation if it's really bad. I think there was a study I saw today even that, is indicating survivability improvement on early intubation for non-COVID patients. And so it's one of those things that we have to be cognizant of like, what is the trajectory of a patient and how quickly do we need to act on some things. And then, the really definitive treatment for most of these is going to be some form of antibiotics. The viral stuff, if it's just a viral pneumonia, it's hard to treat. COVID is one of the few that we have a lot of resources for now, antivirals and things like that. Most of the other ones, they kind of run their course over time. The flu viruses, we have some treatments for that, the Tamiflu. But most of the others, they're not often seen enough, and they are difficult to culture, and so we can't like target anything specific. But bacteria, we kind of go off of what's the most likely. Treat broadly, because it's always easy to narrow afterwards when people are improving. It's much harder, and it kind of feels bad if you're having to go wider for someone who's not getting better after you started your treatments. So that's typically the way we approach it. It's kind of a shotgun approach, and then once we get more information, we narrow it from there. So here's our calculator. Oh, that's not as big as I thought it would be. So it's one of the validated ones. The Pneumonia Severity Index is on the left. And the reason that these are important, besides just determining whether someone's going into the hospital or not, is depending on how many points you get based on all of these little check boxes and things, it's kind of an indication of your mortality too. So depending on which one you look at, it's roughly a 25% mortality if you've gotten over a certain threshold. And it gets to that threshold pretty quickly, especially with age being one of the criteria and living in a nursing home. You've already gotten 60 points or what. It's 1 point for each year. And so you think about that. The older you are, it goes up very quickly. And so we have to be, very aggressive and treat it, seriously early on. And the other things that go with it are just stuff you would see in severe illnesses, regardless of the type. Sepsis and other variations of things that you've heard of before. We looking at vital signs and labs and other organ failure and things like that. So the main other part of this is we want to be concerned about trying to prevent some of these complications that come with pneumonia. The first one being parapneumonic, meaning kind of over the pneumonia. So if you have like that, if you remember that X-ray, if you've got pneumonia in this right lobe, you can develop fluid around that, and sometimes you can get scarring, and the scarring part can be very painful. The fluid we can drain off. Also abscesses, acute respiratory distress syndrome is the big thing that we want to watch out for, because that's the thing that more often kills people. It's a very quick onset respiratory failure that requires intubation and mechanical ventilation, and there's tons and tons and tons of studies and protocols and things like that to try to get someone over that initial insult, but it's very difficult. And so if we can prevent that, that's great. But we have to be quick about early interventions if that's looking like it's going that direction. Sepsis, as I mentioned, is also any sort of infection can lead to a sepsis kind of picture, and so we have to be cognizant of that too. So I'm going to hand it off to Dr. Porter to talk about ways that we can protect ourselves.
So Eric, maybe you could go back to the last X-ray. I just thought they might find it interesting and more helpful if you kind of point out what's abnormal on there. You and I look at those all the time, but they're not going to know
that laser pointer.
Yeah. There you go. We don't have a laser pointer, but
yeah, sure. I think it's easier to compare it to this one because this one's very fairly obvious. So all of the dark stuff we're looking at is kind of the air in the lungs. Air is translucent. X-rays bounce off of stuff that are more like bones. Bones are going to be, down the middle you've got the spine, and kind of around there you can see the ribs. So bones show up brighter on X-ray, air shows up darker. So with that in mind, we're looking at stuff, you got the heart kind of in the middle. Oh yeah, I do need a laser pointer, don't I? So you've got the heart kind of in the middle, and you can see there's the borders of the heart. When you can see those, it's not too bad. Sometimes with these lobar, infiltrates, is what we call them, or opacifications, meaning they're more opaque on X-ray. You've got more debris in that area, more inflammation. It can be, a lot of times what you're seeing on X-rays is going to be signs of inflammation in an area. So that's kind of what that is, and it's sort of localized to this one lobe. Whereas if you're seeing on this one, not as much dark space, but not consolidated to one area either. It's sort of a diffuse white, haziness is one of the radiology terms. And so all of the haziness kind of on the right side of the screen, left side of the chest, and left side of the screen kind of close to the middle. All of that stuff is generally just a sign of inflammation everywhere.
Kind of almost a granular sort of whiteness, kind of diffusely out there, and then some fluffy lesions that are departure from the darkness of the lung itself.
Yeah. So in different clinical contexts, this can mean very different things, even though it's the same image. So if it's a heart failure thing, that could all be fluid from your congestion. In these cases, since we're talking about pneumonia, it's most likely an atypical pneumonia, but that's where the doctor explaining what's going on comes in handy, because the clinical context really helps guide what they're doing, what you're seeing, and what all of the data mean.
All right, so we're just talking about some preventative measures that you can take and to prevent yourself from getting pneumonia in the first place. I was also going to just add real quick, if you look at that previous, those two X-rays, That was a pretty bad atypical pneumonia, but generally speaking, the other name for that is a walking pneumonia. So people can walk around and get along pretty well sometimes, and then take an X-ray that looks very diffuse and kind of just ugly like that last one. So it's surprising sometimes how bad some of those X-rays can look, and the patient clinically is doing okay. So, but on to prevention. So we've got 3 primary pillars for the prevention of CAP. So if you see the CAP, that means community-acquired pneumonia. The big one here, and one that I know most of you have already done, is smoking cessation. So if you are a smoker, please stop. And if you're not, then congratulations and thank you. Your health will thank you for it. So that's a big one, and I know it's one of those things that's easier said than done. But if you can do it, you've diminished a lot of unnecessary risk right off the bat. The second big one is influenza vaccination, and I know how successful you guys have been here with COVID vaccination, with some 99.9% vaccination rate, and I'm assuming that your influenza vaccination rate is likewise. If not maybe that good, but very good here. So that's another big step that you can take to do that yearly, and just another step that you can take to prevent the risk of developing pneumonia. One of the things that influenza will do is it kind of, when you can get sick with it, will kind of set the stage for a bacterial pneumonia to set up shop, if you will. So it's not always the influenza that actually gets in there and really causes a bad pneumonia, but sometimes it'll set you up to have a bad pneumonia later on down the road. And then the last thing that we do that we'll spend a lot more time on is getting the pneumococcal vaccination. Now, one thing that I want to point out about that is this does not prevent you, and is not intended to prevent you from getting all pneumonias. Okay, so this is a vaccination against the most common bacteria that causes pneumonia. How much it causes, I was looking this, it's probably older studies was somewhere around 15% of pneumonia cases, more recent studies around 20 to 25%. So it's an easy step to improve your chances about a quarter or so, quarter to a fifth reduction in the risk of you getting a pneumonia. I don't know if any of you are classic scholars, but those are the 3 kinds of Greek columns that you see in ancient Greek architecture, so I just thought I'd include that. You got your Doric, Ionic, and Corinthian. So, all right. How can we protect from getting pneumonia? So, briefly, there's 2 main kinds of the vaccine. So you have the polysaccharide vaccine, PPSV for short. There's just one of these now, and it's made from a partially purified pneumococcal capsular polysaccharide, which is a big mouthful. And it targets 23 serotypes, and the word serotype basically means slight variation. So there's lots of serotypes of this bacteria, and a way to think of a serotype might be we're all humans, so we'll say pneumococcal, but we all have different hair colors and hair types and skin colors, and so those are the kind of the serotypes. So it's still the same bacteria. It just looks a little bit different on the outside, and because of that slight variation, how it looks means that your immune system will need a slightly different response to counter it. It's a similar idea to what we see now with COVID, with the different variants popping up. So, but one of the things that we'll see is, so this was created, and when it was created, it was created to target these serotypes that were common in the 1980s, and those most common serotypes have kind of changed over time, and they've changed largely because of the second one, which is the conjugate vaccines, or PCV for short. These are pneumococcal capsular polysaccharides, So this stuff doesn't really matter too much. It's just the way these things are attached to glucose or like carbohydrate molecules. But these were initially developed for pediatric use, but more recently they have been developed to target more of the common serotypes that are more common in adults. And the last thing that they do really well is they allow for mucosal immunity, which means that your body will prepare an immune response in the mucosa of your body. So, in the back of your throat, in your nose, areas like this. This has two big effects. The one big effect is it helps with herd immunity big time. It makes it less or much more difficult to pass from one person to the other. But because of that, it is what has sort of kind of resulted in the proliferation of other serotypes that that vaccine doesn't target. And so now the PPSV is kind of less effective because those serotypes that were common in the 1980s that it was initially made for are less common today. And so this is kind of hot off the press. The CDC has basically just reissued some guidelines now for pneumococcal vaccination. And so now there's a newer vaccine called the PCV20. So initially it was the PCV, it was the 23 and the 13 that everyone was getting. Now they're recommending that you can just get the PCV20. And if you haven't gotten anything else yet, you can choose between the PCV15 or the 20. And so if you choose the 20, you're done. And if you choose the 15, they recommend that you wait a year, and you could get the PPSV20. It's very convoluted. I would recommend just getting the PCV20 and being done. And if you've already gotten one of the older vaccines, then you can kind of follow up with that. So if you've gotten an older one, like the 23, then after, as long as you've waited a year, then you can either choose from the 15 or the 20. That's this bottom lower right-hand box, and you can kind of call it quits there. If you haven't gotten anything and you choose to go with the 15, then you can wait a year to get the 23. Or if you are someone that's immunocompromised or has someone that's at risk, then you can move that up to 8 weeks if necessary. Then on the left-hand side there, this is all these reasons why you might need to get it. It recommends it for everyone though that's 65 years or older. If you're under 65, then if you have some of those conditions, then you should. They recommend that you get it. And a lot of those, there's some very common conditions on there. So. It's very easy to meet that recommendation. Diabetes being one of them, cigarette smoking being one. So, but yeah, so this is kind of new. I mean, this was new to me. I had to learn about this when I was putting the slide together. So, you guys are honestly now more up to date than most doctors. Yeah, it's very new. And this slide, this is just kind of rehashing what we just talked about. One thing I will note, you can barely see it there at the very, very bottom, is that it is safe to administer these vaccines, the 15, the 20, the 23, at the same time with the flu vaccine. So with that quadrivalent flu vaccine. So that's something that you might have a question about with your doctor, but the CD says that is a safe thing to do. So I know that you can't read this, and I don't expect you to, but these are just the serotypes that all these different vaccines cover. So you can see where there's some that aren't covered, but by one vaccine, and others that are. So this is, when we talk about getting, maybe needing more than one of them, especially more so in the past, it was to try and prevent something from basically falling through the cracks. If you think about like Swiss cheese, you got your little holes, but if you put up a bunch of separate slices of Swiss cheese, it's hard to go straight through, right? Something should catch it. I don't know if that was the best analogy, but I missed lunch today, so maybe that's what that was about. This is also very small, but this was on the previous slide as well. Just reasons why you might need the vaccine. And this shows you the effectiveness. Now, this isn't the vaccine that is common for us now that we use, but you can see where the PCV7 was first introduced, which we don't really use anymore. You can see the reduction in pneumonia cases. And after the 13 was introduced, and then even after it was kind of introduced for those over 65, you see this kind of slow and methodical, regression of pneumonia cases. So it is something that works. Real quick, we thought it was worth covering this because this is something that you probably have heard before and you'll probably hear again. And it's aspiration pneumonia. It's in that same sort of family. It's an issue, it's an issue with the lungs, but it's not pneumonia in the sense that you normally think about it having some sort of infectious etiology necessarily. So, aspiration is basically anytime you get something in your lungs that's not supposed to be there, usually coming from your oropharyngeal secretions or gastric content secretions. Big risk factor is if you have any sort of instrumentation done, like an EGD or something like that. But then, also just vomiting or regurgitation. These all put you at risk for having some aspiration. So, you might, basically, your stuff that is not supposed to get into your lungs is making its way down there, and it irritates the tissue. It makes it upset. If it's gastric contents and you have acid in there, you can get kind of a pneumonitis. Let's see. So it's also normally can usually be. It kind of sets the stage for an infection to occur, and then if you do get an infection, it's usually kind of some different bacteria. And might require a different set of antibiotics than what we would normally use for pneumonia. So it's important for us to know if we think you're at risk for an aspiration pneumonia, because we might want to change things up a little bit. And then down there at the very bottom are some of the big risk factors for aspiration. Altered consciousness is a big one, probably the biggest one. And then you can see there, GERD and esophageal motility disorders, but really GERD is the other big one. These are two common things that can happen. So there's our references. So
and kind of a point to that, when if you ever hear or see someone freaking out about a patient or your loved one or something like that who's not responsive, meaning like you try to wake them up and they can't wake up or something like that. And one of our first thoughts is we have to protect the airway and get them intubated, and it's for that very reason that you can develop aspiration pneumonia, and that's more of an over time thing. But you can also develop what's called aspiration pneumonitis, where you get acidic stuff in your lungs, and that causes a lot of inflammation, and that can make you sick very quickly. And so what we really want to do first is make sure their airway is secure. So if it sounds like someone, when someone passes out drunk, for example. The old wisdom is to turn them on their side, so if they throw up, they don't choke on it, that sort of thing. But in the hospital setting, we do that with a breathing tube, so it can't get down there. But it can be very serious, which is why we all kind of scramble and freak out a little bit when that happens.
Great, good. Covered everything very well, I think. And I think they're open to questions. Anybody has any, I'll bring a microphone to you.
My question is, how often should you have a shot for this, vaccination for this? One of my doctors asked me when I had my last shot, and I have no idea. It seems to me it's been several years ago, but I haven't found a record of it, and I don't know how often, if you can get them too close, or if you ought to have one every so many years, or what.
Great question. You're the ones up to date on this, on the latest version. What are they saying about that?
Yeah, it won't hurt you to get it again. And if you remember back there, for patients that we felt were immunocompromised or were at particular risk, they could get that up to 8 weeks after the previous one. So you can get that to follow up on pretty quickly. I believe that this is a one-time deal. You get the 20. I do what? Well, now now it's the 20 probably, because between the 20 and the 15, if you get the 20, they say that's good enough. You don't need anything else. If you get the 15, then they say you can get the 23 later.
So
if you would like.
I've just been presuming the 20. If you get it after 65, so far they're not recommending any further ones after that.
Yeah, my understanding is
Dr.
that's it.
Ezel will know the latest.
This is hot off the press. It came out a couple of months ago, but here's the bottom line. If you get the new one, the 20, you don't need anything else. That's all you need. If you've got one of the older ones, the 13 or the 23, you might need another one. It depends on what you got and whether you got it at a young age or after you turn 65. It's not simple. It's hard to keep up with. It changes all the
And they go changing it.
But the long and the short of it is, this new one, the PCV 20, if you get that, you're good. You don't need to worry about getting anything else. That's what they told us when we got that other one. On that other one, if you got the 13, you needed the 20, correction, 23 a year later. If you got the 23 first, you needed the 13 a year later. Once you got both of them, and you're past the age of 65, then you were good to go.
Then you're good. Yeah, the previous wisdom was they would do the 13, when you turn 62, 3, 4, somewhere in there, and then at 65 you would get the 23, and then you were supposed to be done after that point. Now, to your point, I have seen some people who would get it, give it annually or semi-annually, and that was just unnecessary. But nowadays they're saying the PCV 20 is the go-to catch-all for everything, unless you're a high-risk patient. And some of those people on the high-risk list were cancer patients, patients on organ transplant patients, things like that, who would be at a higher risk of any infection.
I have a question actually for Dr. Ezel real quick. Do you know if there is any reason to choose the 15 over the 20?
As far as I know, there is no reason. If you get the 15, for whatever reason, then you still either need to get the 20 a year later or the 23 a year later. There's no advantage to getting the PCV 15.
So everyone, I would always just have my patients get the 20 then.
As would I.
One stick and done. Okay.
Once and you're good.
Okay.
I tell you, all of this is bringing a laugh to me. My long career has kind of tracked this. I was probably in my first decade of practice when they came out with the Pneumovax initially, first time. It's good for 3 years. I'd already given it to some people at 3 years when they said, no, it's good for 5 years. I'd already given a lot of people that for 5 years, and they came out and said it's good for 12 years. And then it wasn't long after that, and we're talking probably 10 years as this goes, this whole story. But they're saying, oh, you just don't have to take it again. And then you see what it's come to now. So, believe what I say for the moment, but then it's probably going to change. Do you know, I think one of the things implicit here, you probably appreciate, as do I, being in the same age group, that they didn't dwell on it, but the reason this is so pertinent to us in this room, the majority of us, is that we are at risk. So, what I've learned during COVID is at risk puts you at the front of the line. Hey, that's all I had to say, and I get the first vaccine. That's been great. But I was on vacation a few years ago at the beach, and I'm not a beach person. So after a couple of days, I'm looking for something else to do. My wife mentioned going over to the outlet mall down the street. I said, sure, I'm all ready. And I'm checking out from this retail store. And on the counter, it says, here's the 3 discounts. If you're military, or if your family works at the mall here, or if you're a senior citizen. And I said, well, how senior do you have to be? And they said, well, my boss says that anybody admits they want that, you don't even ask any questions. I said, well, I would have taken that 20 years ago. Anyway, yeah, we're eligible. Yes, ma'am.
Okay, you're my primary doctor. Are you looking at my records and saying, oh, she needs the flu shot or the pneumonia? Or am I supposed to decide?
Well, we want you to decide, but no, actually, when we see you for routine follow-up, that should be among the things we're looking at, but especially, and most of you who are patients of the clinic here, the UAMS clinic, we're trying to encourage you to take advantage of that Medicare annual wellness visit. And we go over all that. We go over everything preventive, everything screening, all vaccinations, end-of-life wishes, everything else. So, but we should, we bear real responsibility there, but this is a pretty savvy group, and we're not surprised, and we're pleased when people come in and say, I'm due, or whatever, or want to know. The easy one to remember is the flu vaccine, because it's every year. It's every year, and it really is, for a lot of the reasons he said, just as important. In some ways, maybe more important than the pneumonia vaccine. So everybody should be thinking about that. Other questions? Yes, sir.
Well, the COVID, in relation to other types of pneumonia, is it a specialized one? COVID pneumonia?
Not exactly.
Is it
It's
COVID leads to?
So it's one of the, because as I was saying a little bit earlier, it's
How
what,
deadly are they?
so, as I was saying earlier, so it falls under the umbrella of atypical pneumonia, because it's kind of a diffuse pattern. On that being said, if it's bad enough that you end up in the hospital, it's a very severe atypical pneumonia, and it's widespread inflammation, a lot of scarring and things like that. And so while it falls under the umbrella of atypical pneumonia, in the normal cases, where you were sick for a couple days or never went to the hospital and all that sort of stuff, we don't really know how it's going to play out over time. The really severe cases looked way worse than what I showed you up there, and they, even to the point that they can end up on a ventilator, which is not different than other pneumonias, but it's unusual for the quote-unquote atypical pneumonias, because those more often than not are pretty easily treated and run their courses very quickly, we hope. COVID, however, has had this prolific inflammatory response and all that sort of stuff that just causes a lot more damage very quickly than we would normally expect. And because there were so many more cases of it than what you would see in a normal flu season, it garnered a lot more attention.
Yeah, and I might just point out, there's a distinction between, we tend to say it's just a virus. It's going to run its course. And for a lot of these respiratory viruses, that's true. But when it comes to viral pneumonia, we don't have a lot to treat it with effectively, like an antibiotic. But many of those, because we can't treat them, and if they're progressive, many of those wind up on ventilators. So it's just the treatment often in those severe cases is supporting the person oxygenation-wise, ventilation-wise, until they cycle out of the infection. Can be that way with COVID, although COVID is a special creature we all have come to know. Yes, ma'am.
I cannot remember if I had the pneumonia shot. So do you think it's wise just to go get the number 20 shot or vaccination?
I don't think it would do any harm.
So, one thing you should know is that this is not just our clinic. It happens in our clinic every day, but most primary care clinics. We can do a tracing or a monitoring of from the state's records on vaccines. You've got a list of medicines that you don't even know about that we can call up in the clinic that tells us every vaccine you've had since they've been keeping the record of it. Now, some people slip through the cracks, but if you get it, whether you get it here, or, in a clinic or in a pharmacy, they submit that, and so it winds up on your record. So sometimes we don't know and you don't know, but we find out and when we access that record. So. Yeah, oh yeah, it would. If they have it, they'll have everything about it.
I asked my druggist to check my records, and he couldn't find where I'd had mine, but I know I had one years ago. I don't think the state has been keeping all that for that many years.
I was going to say, it may have only been 15 years or so. I'm sure isn't for the last. I'm sure it wouldn't have things 30 years back. Do you know, Dean or Alice? There's a limit, but most of the questions you would have about whether it's advisable or not would be answered by what you've had in the last 15 years, honestly. So if you'd had something 30 years ago, you probably need it again anyway, because they've changed them enough. So, out of state, it's going to be hard. We're just going to have to take our best guess. Sometimes if you've got a clinic that you got it through, we can call and find out. But sometimes we just proceed under educated guesswork. So, yes, Dr. Helen.
I'm sure that everybody is onto this and it's clear, but I think it's worth mentioning when we talk about these vaccines, it's a vaccination and it provides immunization only against one kind of pneumonia, and that is the Diplococcus pneumonia, or the streptococcal pneumonia. And so I want to ask these fellows something, and that is this. You spoke of the fact that there is such a thing as a conjugated vaccine as opposed to the one that is not conjugated. What is the advantage of the conjugated vaccine in terms of the immune system?
Yeah, I looked at a chart about that, and there's a bunch of, I didn't include it. Like I mentioned, one of the things was the mucosal response and the herd immunity that you get from having it conjugated. I know that you know the answer to this.
Dr. Helen.
And I know it has something to do with T cells and B cells and how they how
is there an immunologist in the room? Oh, Dr. Helen. She can answer that question.
I know.
Those are great questions. I don't have the answer.
What's the answer?
Very basic immunology, and that is that good antigens, and antigens are substances, molecular materials that best stimulate an immune response. And so the best antigens are proteins. The mucosal antigens are not very good antigens. And so what they've done with this conjugated vaccine is to take a really good protein molecule, antigen, and complex it with the polysaccharide of the organism, and it makes for a complete immune response. Not superficial, but involves both the B and the T lymphocytes.
There.
Dr. Ezell, if you have any need for an extra specialist, either part-time, I don't think she's looking for full-time, or you just need a speaker on immunology. Here she is. She might have had to have disconnected. You get a lot of questions.
It's important that this new vaccine 20 is a conjugated vaccine and is going to be really, I think, very effective, very, very good, and get a complete, efficacious immune response to it.
Thank you. So, and that's really good. Y'all have now both pointed it out. This pneumonia vaccine doesn't prevent all pneumonias. It's just this one organism that happens to be the more common pneumonia in the community, but that's worthwhile.
The streptococcal pneumonia organism is very common in the environment, very common. We're all exposed to it. People who do not have any symptoms whatsoever carry it around in their noses and throats. And so the minute then that a person can become susceptible, you can get that pneumonia. So how does it pass? What is the epidemiology of it?
I mean, it's through respiratory droplets that are inhaled. Is that what you're asking? Yeah, I mean, yeah, it's usually through respiratory droplets, cough, sneezes, and very similar to the way COVID is passed from person to person. One of the things that when we talked about with prevention is, I didn't mention this, but the importance of, I think the point that she's making here is, if you're probably exposed to it kind of all the time, at just a low basal rate, and so if you're not taking care of yourself, or if something you start to become susceptible, say you get some other illness and you're bedbound for a while, that's setting you up for an infection. That's why this is an infection that's very, very common in hospitalized patients that are in the ICU for extended periods of time, or just in the hospital for an extended period of time, because they're setting their bodies up, setting their lungs up for the prerequisite conditions to develop the pneumonia. So, some of the things that we'll do in a hospital is give you an incentive spirometer to suck in and keep your air spaces open, keep them working well. Just keeping you up and moving as much as possible while you're in the hospital.
And the great things we've learned over the pandemic of preventing COVID spread. If you're coughing, you don't have to know you have COVID. If you could spread any of this, a mask is a great thing. Sneezing into your elbow is a good thing.
May I ask one more question, and that is this. What is the immediate cause of death when a person dies of pneumonia? Is it deprivation of oxygen only?
That's kind of a multifactorial question to answer, because it would depend on the clinical scenario. If we're talking about purely in the lungs, then ARDS would probably be the most immediate cause, and that's what we talked about earlier. It's the acute respiratory distress syndrome, and that's kind of what COVID does. Is it causes this massive, out of control, rampant inflammatory response, and then you're not able to oxygenate your blood. Now, if we're talking about kind of sequelae of having an infection, a pneumonia of some sort, we're looking at, I think I saw a number, I forget exactly, I want to say maybe 25% of people who have pneumonia also have bacteria in their blood, and that can very quickly lead to what we call a septic picture, where your blood pressure is low, your heart rate's high, you've got inflammation all over your body, and that can also lead to death.
The first thing he mentioned, the ARDS, adult respiratory distress syndrome, is the end stage for a lot of people. Although obviously septicemia could be, but if he threw an X-ray up of that, it would just be both lungs whited out, just full. So it's in that situation.
I mean, ultimately, your heart is not getting enough oxygen, and it goes into some lethal heart rhythm. it results in, cardiorespiratory failure. But that's how basically everything gets you eventually. But yeah, lack of oxygen.
One last question.
During this COVID, they talked about ventilators all the time and the need for ventilators. And I wonder and then I guess they talked about intensive care in addition to that, but they also talk about respirators sometimes. I think, maybe I don't remember that, but what exactly is the difference between a ventilator and a respirator?
Sure. Yeah. I mean, that's a good question, especially if you're not
Thrown
working around all this stuff. I think the best way to explain it would talk about the degrees of respiratory support we can provide. So the first kind of most basic one would be just an oxygen hose in your nose. And that's going to provide, some support, and a lot of times for people, that's all they need. The next step from that would be high flow oxygen, which it's a bigger hose and it's got some pressure behind it, and that can, you can crank that up pretty high. The step from that would be, if you've ever seen with sleep apnea, like the CPAPs, there's another specialized version of that kind of machine that can be used for helping with if you're retaining carbon dioxide, meaning you're not breathing enough, it can help with that. Then the next step with that would be the ventilator, which you were talking about, and that's where you have to basically put someone under a anesthesia and put a tube in their trachea, and so that you're using a machine to breathe for them. And the benefits from that they're huge when needed, because it can provide extra pressure, it can provide extra oxygen. You can change up the breathing modes and methods, and there's about 15 different settings and an entire specialty and fellowship devoted to learning how to use that thing. And then the next step from that would be what's called ECMO, which we don't do up here, I don't think. And that's where they actually bypass the lungs with a machine so that you can oxygenate the body directly. And that's what we saw a lot with COVID, was that there's just so much inflammation that you had to bypass the lungs because even the ventilator wasn't able to get oxygen to the blood. And so that's where they do it kind of directly. And so it's a stepwise fashion, but we also don't want to be we want to be a little bit cavalier in getting person to the right point at the right time, because if you lag behind too much, then you're playing catch up and then they end up dying.
Thank you all. I want to tell Dr. Ezell and Dr. Alexander, this is a tough crowd. They've got their questions. They're not always easy to answer, and that's what I love. They're always engaged. Thanks, everybody, for coming. And next, so I'm going to go ahead and plug next month. The residents who are here are going to be talking about the beers list. And that's not the list of best craft brews out there. The beers list is kind of the bad list of medications for older adults. We need to know about that, and that'll be a great discussion, I think. So I hope you'll be here next month. Thanks for coming, everybody.